Good evening, everybody, and welcome to today's episode of Marvelous Medicine, which is on managing childhood diabetes. We are very happy to have Dr. Hemchand Prasad as a speaker. Dr. Hemchand is a consultant pediatric endocrinologist at Mehta Hospital, Chennai, and is an honorary consultant at the Department of Endocrinology of Madras Medical College. Dr. Hemchand did his MBBS from Madurai Medical College, MD Pediatrics from Madras Medical College and Institute of Child Health EGMO, and a fellowship in pediatric endocrinology from the United Kingdom. His areas of interest include growth disorders and type 1 diabetes. He has about 50 peer-reviewed index publications and has authored and edited textbooks in pediatric endocrinology. He is the associate editor of the Journal of Pediatric Endocrinology and Diabetes and has developed apps which are free for pediatricians to use in the management of diabetes. He is a much sought after speaker at the national and international meetings and has received several awards, including an Innovative Teacher Award. Thank you, Dr. Hemchand, once again for taking time out for Marvelous Medicine. Moderating the session will be Dr. Parvati, who's a consultant in pediatric endocrinology at Aster Medicity, Kochi. Dr. Parvati did her MBBS from Government Medical College, Trivandrum, MD Pediatrics also from Government Medical College, Trivandrum, and did a fellowship in pediatric and adolescent endocrinology from IGICH, Bangalore. Thank you, Dr. Parvati, for being extremely prompt in accepting our invitation for this session. Over to you, Dr. Hemchand.
Can I start sharing my screen, ma'am?
Yes, please.
Good evening, everybody. Thank you.
Dr. Hemchand, 1 second. I think Rekupati sir has joined. Dr. Vidya, my mentor, Professor Rekupati, has joined from Bangalore. I think, welcome, sir. Can you hear us, sir?
Yes, I can. Thank you very much. Thank you very much for letting me know about this program. And Dr. Hemchand, good evening to you, and wish the program a big success.
Thank you, sir.
Thank you, ma'am. Thank you, sir. Can I start, Dr. Vidya, ma'am?
Yeah, absolutely. All yours.
Yeah. Right. Thank you so much. So I think thank you very much for this nice invitation. And I think all of us know very well that childhood type 1 diabetes is an epidemic in itself. The awareness has improved, the prevalence has improved, and I think it's very important that all of us team up together and work as a team and improve their quality of life. So over the next 30 to 40 minutes, the focus of the presentation would be on answering these 10 focused questions. Why childhood diabetes mellitus is different from adult diabetes mellitus? All of us would want a child who eats like this. D would signify dosa, I would signify idli, and R would signify 1 cup of rice. Everybody would be happy to have a child with diabetes eat something like this, which also can happen. But more commonly, you would encounter a child who eats like this, who eats anything and everything on the earth and definitely has the right to do so. And somebody who would graze like this, eat every 40 to 45 minutes, like all of us do. I definitely do. I'm sure many of us in the audience would definitely do. Graze, eat every half to 1 hour. And number 4, binge eat. All of us at some point of time in our lives, we do have done this binge eating. This was the story of one child who binge ate 3 packets of A to B Murukku packets. And that is binge eating, which they are also entitled to do. And enjoying birthday parties, having a piece of cake, having a cup of rice, having some soft drinks on an occasional birthday party, and enjoying festival. This is a Pongal Day, a very special festival of South Indians, where this child has had 7 meals on that day with variety, payasam, sweet pongal, vada, etc., appalam, etc. And varied eating. Some days they eat nothing, like you can see this child who has eaten nothing on a particular day except 2 spoons of curd rice, and next day she goes on an eating spree to eat anything ranging from Fanta to some milk biscuits to some Complan, etc. So the dietary and eating pattern and childhood, if at all of us remember, we have only two fond memories, eating and playing. I think a child with type 1 diabetes is indeed entitled to undergo all the flavors of childhood, how to say, that is associated with childhood and Indian diet. So children with type 1 diabetes mellitus are also normal children. They do enjoy birthday parties. They do enjoy all festivals. They must be occasionally allowed to eat unhealthy calories. They do have food tantrums, food cravings. They do grace, and they do have sibling rivalry. Why one sibling is allowed and other sibling is not allowed. Management of diabetes is not just managing childhood sugars, but it's also managing the childhood component of type 1 diabetes that comes into play. So, and this is stricter with the most stringent guidelines, the most stringent targets that all regulatory bodies, academic bodies put across and tell us maintain sugar under tighter control. They are caught between the devil and the deep sea, so to say. The long-term repercussion of an early onset of diabetes and the risk of hypoglycemia, which they may or may not be able to voice out. So, I think children with type 1 diabetes mellitus are extremely complex, varied, and a thorough understanding of childhood is very important to optimize their management. Having understood the complexity, what is the ideal regimen and what is the ideal diet for every child with type 1 diabetes mellitus? I think the writing is on the wall. Everyone would definitely agree. All academic bodies tell us only one thing: basal bolus regimen. I repeat, basal bolus regimen is the only regimen that is ideal in all children with type 1 diabetes mellitus. What does it involve? It involves checking, counting the carbohydrates, and injecting, followed by a diet. Why should you check? When you find the sugar value is above the target, you would add a correction dose. Very young children below 12 years would require 1 unit of bolus for every 100 milligram above target, and older children and adolescents would require 50 milligram of sugar. 50 milligram would require 1 unit of bolus insulin for the CBG value 50 above the target. Look at the carbohydrate content of the food that the child would eat. A younger child would require 1 unit for every 15 grams of carbohydrate. An older child would require 1 unit for every 10 grams. These are rough starting doses that would have to be modified with time. Once you have assessed the dose that has to be given, you would give the bolus injection followed by a diet. Let us see how it works. It looks complex, but it's very simple as you practice it day to day. This is a child who began in the morning with a sugar of 167, and for breakfast the child decided to take 3 idlis, 1 cup of sambar and 1 cup of milk. The child's sugars are in target, hence does not require any dose for correction. But if you look at the carbohydrate content of the food, the child is going to have a meal that contains 75 grams of carbohydrate. So 1 unit it's like currency. It's like petrol, the mileage of a petrol. 1 unit would be needed for 15 grams. So 75 grams of 75 grams of carbs would require 5 units for the carbohydrate, and the total bolus dose is 5 units of bolus dose. The same child, if he had woken up with a sugar of 300 milligram per deciliter, then the child would require 1 unit for every 100 milligram above target. So you would add 1 unit and you would give 6 units of bolus insulin. If the child is very hungry and decides to eat 4 idlis instead of 3 idlis, then the carbohydrate comes up to 90 grams. So the dose for the carbs goes up to 6 units, and the child would be given 7 units bolus dose. Whereas for lunch, if you see the sugar is 167, the child decides to eat 1 cup of rice, 1 cup of curd and 1 cup of beans poriyal. So for the 75 grams of carbohydrate in this meal, the child would be matched with 5 units of bolus dose. If the same child has a sugar value 300, you need to add 1 unit for the correction and you would give a 6 unit bolus dose. And if the child is very hungry and decides to consume 2 cups of curd, then you would increase the bolus dose by 1 unit, and you would give 7 units bolus dose. The amount of petrol your vehicle needs depends on the distance you have to travel. If you have to travel from the city center to Tambaram, you would need 2 liters of petrol. If you have to travel from the city center to Chengalpet, you will need 5 liters of petrol. The higher the distance you have to travel, more would be the petrol requirement. Higher would be the carbohydrate content of the meal, more would be the bolus dose. Lower the carbohydrate content of the meal, lower would be the bolus dose. Deciding the basal dose is relatively simple. Depending on the age of the child would require a dose based on the weight and the percentage bolus, roughly working out to around 0.3 to 0.4 IU per kg would be the rough starting dose, but this is tailor made based on the timing and the sugar values. This is how you would initiate a child on basal bolus regimen. Once you decide to put the child on basal bolus regimen, the choice of insulin is varied. It depends on the pulse, it depends on the feasibility, depends on the availability of the medication. Preferably, one would use younger children on insulin analogs like Aspart, Lispro or Glulisine. If the only insulin is available is regular, that can be used as a bolus insulin for 3 meals in a day. 1 dose of short acting for breakfast, 1 dose of short acting for lunch, 1 dose of short acting for dinner, based on the preference of the unit, and basal insulin, peakless insulin, Glargine, Basalog, Tresiba or Degludec. The choice of basal remains the individual unit's prerogative, but the concept of basal and bolus is very important. The delivery device again depends on the unit, the economics, the feasibility. The insulin can be delivered by a syringe, by a pen in most of the cases, and occasionally by a pump. So the concept of basal bolus is eat what you eat, whenever you want, how much ever you want, you give the accordingly. You will have to calculate and give the bolus. Bolus is given for breakfast, lunch and dinner, and a basal preparation is given to cover the 24 hours requirement of insulin. Thus, in basal bolus, we are adjusting the shoe size for the foot. We are adjusting the glove size for the hand. We are adjusting the cap size for the head and not vice versa. So the message of this talk, if at all it conveys something, would be all children should not be on fixed doses but on individualized doses based on the meal they are consuming, the age and the individual situation. More you eat, more the bolus; less you eat, lesser the bolus. Dietary management of type 1 diabetes is no different from children without diabetes. Exclusive breastfeeding, appropriately timed complementary feeds, structured timely meals, avoidance of junk, calculate the carbs and give the dose. The more you eat, more would be the dose. Lesser you eat, lesser would be the dose. Lot of material is available, including the website of the Indian Society of Pediatric and Adolescent Endocrinology, and lot of healthy apps which give you the carbohydrate content. You can prepare and give them a carbohydrate containing list with the amount of dose they would have to take for every meal based on the list that you are providing. So, what is the alternative if the noon injection is not feasible? Occasionally, maybe both the parents are working, there is no feasibility of giving an injection at the school, it's a hostile system, or there is no nurse that is available to supervise. In such specific situation, you could offer them the option of split mix. You would assign them doses to take in the morning, consisting of a short acting and a long acting. The short acting, you assess the total requirement and divide it into 2 doses, and you divide the doses into short acting and long acting preparation. The morning short acting covers the breakfast. The morning long acting, that is the NPH, covers the lunch. The night short acting covers the dinner, and the night long acting covers the overnight requirement of the child. All you need to do is ensure that this child would eat the specific amount of carbohydrates on that particular time, and exchange, try to juggle around. All the food items depicted in this table have an exchange list of about 4 to 5. So one ensures that the appropriate amount of carbohydrates are delivered during the lunchtime so that there is no hypoglycemia at the lunch or a hyperglycemic excursion that takes place as a result of lunch meal. These are the different combinations that are available for lunch. Those are the combinations available for breakfast. It's a compromise. You give two peak insulin, that is a short act. You mix. You never use pre-mixed insulin. I think that is another important message. Never, never, never pre-mixed insulin in growing children. Adjust the insulin for the food that is eaten. That is the most important thing. A breakfast to cover an insulin to cover the breakfast and the lunch, and another shot in the night to cover the dinner and the overnight requirement. Of course, this is a compromise regimen where you are cutting the foot for the sake of the shoes. You are cutting the fingers for the sake of the gloves that you receive. You are cutting your head for the sake of the cap that is received. But I think, remember, basal bolus, where you are adjusting the shoe size, you are adjusting the glove size, you are adjusting the cap size, remains the best and the ideal regimen that should be recommended in all children with type 1 diabetes. To sum up, only basal bolus, only basal bolus, only basal bolus. No role for pre-mixed insulin, no modification in the diet, reinforce healthy eating principles, ensure that the family is taught carbohydrate counting, provide them with a mileage. Your bike would give 10 kilometers, your bike would give 15 kilometers. Provide them with an insulin carbohydrate ratio. Initially handhold them to calculate insulin doses and administer basal dose based on the weight. So I think the message is ideal regimen, and the only regimen is basal and bolus regimen, should be individualized, and the ideal diet is any normal diet based on the recommendations of the World Health Organization and the ICMR. Now coming to handling a child with type 1 diabetes is like handling a mobile phone. The way you get expertise in handling a mobile phone with more and more usage, you get more and more familiarity for physicians in managing day-to-day issues in type 1 diabetes. How would you manage hypoglycemia? Remember, any value glucometer reading below 70 is considered as hypoglycemia in a diabetic child. If you see conventional pediatric textbooks, they would describe any value below 50 in children. Below 60 in critically ill children. In newborn, the cutoff is lower. Because this is a condition which is prone to develop hypoglycemia, it is defined as 70. Any hypoglycemia with autonomic symptoms, sweating, palpitation, tremor, irritability, etc. Any different symptom is mild or moderate hypoglycemia. Any hypoglycemia with CNS symptoms, that is, you have seizures, altered sensorium, coma, is considered severe hypoglycemia. And hypoglycemia without symptoms is the worst. Why? Because autonomic symptoms act like an insurance policy. It helps the family recognize hypoglycemia, early correction, prevention of occurrence of neurological symptoms. It acts like a safety check. So whenever you see a child with hypoglycemia without symptoms, be wary. This child may be slipping into neurological complications later. Be careful. So always see whether this hypoglycemia is mild, moderate or severe. If it is mild or moderate, the rule of 15 grams of carbohydrate in the form of 3 teaspoons of sugar, recheck in 15 minutes and the next snack in 15 to 30 minutes. If you're looking at a child with severe hypoglycemia, you're looking at a rapid increase in the sugars. That scenario, if you're able to secure an IV line, you would give a dextrose bolus, 4 ml per kg of 10% dextrose. If such a preparation is not possible, you would give glucagon. All children, especially infants below 5-year age group, should be provided with a dose of glucagon to have it at home and be given only in the case of severe hypoglycemia. Hypoglycemia, when the child cannot help itself, has neurological symptoms, please provide them with injection glucagon in a dose of 0.5 milligram in younger children and 1 milligram in older children. And third important step in hypoglycemia management, think why it occurred. Is there an insulin carbohydrate mismatch? Have you given more insulin for the carbohydrate the child has consumed? Or has the child told something and eaten something? An exercise which was not managed properly, and are rarely associated disorders like celiac disease and hypothyroidism. And common mistakes which physicians and pediatricians make is ignoring low sugar, treating hypoglycemia without checking, and treating low sugar with chocolate, which contains more fat and delays the rise in the sugar values. A rapid acting carbohydrate, 3 teaspoons of sugar, is the preferred modality of correction of hypoglycemia. Hypoglycemia is low charge in a battery. Document it. Must have autonomic symptoms. Use the rule of 15 or glucagon. Check again. Ascertain the cause and try to prevent the next episode. This is how a physician should approach hypoglycemia in a child or adolescent with type 1 diabetes. The next scenario which a physician can encounter is unaccustomed severe exercise. If you see the ISPAD 2022 guidelines, there is plethora of material that is available on optimization of insulin regimen in exercise. The gross principles remain the same. If you have to understand it in the perspective of a mobile phone, exercise is a stage when there is going to be more balance amount or less battery charge. Because of improved insulin sensitivity, they need lesser insulin, and because of the risk of hypoglycemia, they need more carbs. I repeat, they need more carbs. So, at the start of insulin exercise, if your sugars are high with ketosis, defer it. Try to avoid injecting the insulin in the exercising ring. If it's shuttle, don't use the arms. If it is football, don't use the legs. Reduce the pre-exercise insulin depending on the severity by 1/4 to half. Check more and reduce the dose of the basal as well. Add more carbs. You top up more and you give lesser doses. You give an extra 15 grams of carbohydrate for every 30 minutes of activity, like apple, cereal bars, half sandwich, etc. And always check the sugar before going to bed, because you are at a risk of a delayed nocturnal hypoglycemia if you have exercised severely and have type 1 diabetes. So the crux of the principle, again coming back, is like managing a cell phone. During exercise, you will have to give lesser insulin, more carbs, avoid hypoglycemia, prevent DKA, juggling around. Okay. Next, and the most common problem encountered is an intercurrent illness with type 1 diabetes mellitus. All of us know very well, all children always tend to develop multiple illnesses. Enteric fever, pneumonia, minor illnesses like AGE, cough, cold, etc. How would you tackle that? Remember, the main principle is never skip insulin. Adequate hydration, check more. And during the times of illnesses, the role of the sugar is taken over by ketones. Ketone testing is regularly and freely available either in the urine or in the blood. Be in regular contact with the team, and in the presence of altered sensorium, large ketones and persistent vomiting, it's time to get into the hospital. Analogous to a mobile phone, ketone sickness is like a low battery charge, low balance amount. It's like roaming. Your battery is also going to go away, your balance is also going to go away. So you would have to monitor by ketones. Whenever your urine ketones are moderate or blood ketones are over 1.5, be careful. Whenever your urine ketones are large and persistent and blood ketones are more than 3, it is time to get the child into the hospital. What would you give? If the oral intake is good, try to manage with lot of oral intake. Ensure adequate carbs are received and small doses of insulin are given and the child takes adequate carbs. And what insulin would you give? You would give rapid acting insulin, very short intervals, around every 2 to 3 hours or 3 to 4 hours, on small correction doses, 0.1 to 0.5 IU per kg based on CBG values on a sliding scale. The basal insulin should never be skipped and given on time. So how much insulin would you be giving? You would be given small correction doses, as depicted in the slide, about 0.1 to 0.5 IU per kg, again tailor-made for every child. On these doses, you anticipate that the child won't develop hypoglycemia at one end, at the same time won't develop acidosis at the other end. So a sick child is like using a mobile phone in roaming. You would have to be very careful, prevent the occurrence of DKA, prevent hypoglycemia, give adequate insulin in small divided doses, rely more on ketones, rely less on sugar values, watch for red flag signs aggressively, large ketones, persistent vomiting, altered sensorium, prevent a DKA. An illness is a situation which can trigger the onset of DKA in a child with type 1 diabetes, and if you are able to fight with the child and come out without occurrence of DKA, you have won the battle. What are the precautions? A child with type 1 diabetes gets admitted in your unit for a surgery, maybe a tonsillectomy, maybe a dental extraction, maybe a major surgery like laparotomy. What are the precautions you would keep in mind? Remember, again, a child with type 1 diabetes during the time of surgery is like a mobile phone in roaming. You would definitely have quick depletion of charge. You would also have quick depletion of battery. So you would have to replenish them properly. They do require insulin. Check ketones. Check there is no DKA before shifting the child to the data. The plan of management depends on the complexity of the surgery. Hypoglycemia and DKA should be prevented. Quick and aggressive monitoring must be done. A husband and wife kind of a relationship is required between the treating diabetic team and the operating theatre. A husband and wife kind of a relationship. In minor surgeries, maybe like a dental extraction, UGA-scopy, colonoscopy, circumcision, there is no need, it's a short procedure. There is no need for IV fluids. All you need to do is modify the subcutaneous insulin. Have it as a first procedure in the morning. Just skip the bolus dose. Once the child is able to eat well and does not vomit, you give the bolus dose accordingly. Like an insurance policy that protects you, a professional indemnity would protect you at the time of a crisis. A personal insurance will protect you at the time of a personal emergency. A health insurance will protect you at the time of a health calamity. The basal insulin is going to protect this child with type 1 diabetes mellitus at the time of the surgery when it's a minor surgery. However, a major surgery, coming back to the mobile model, there is going to be a disruption to the system. You need to replenish the battery charge and the battery balance amount as well. So IV fluids and IV insulin is needed. In cases of laparotomy, neurosurgery, craniotomy, cardiac surgery, etc., you definitely will have to start the child on IV fluids. Adequate carbohydrate to combat the period of stress is very pivotal. And IV insulin on a small dose, not as high as a DKA dose like 0.05 to 0.1 IU per kg per hour, but a smaller dose, maybe start off with 0.02 IU per kg per hour and titrate to maintain the sugars in target range. Remember, DKA is a state of counter-regulatory hormone excess. Such a state does not exist during the time of major surgery. So you might escape with a relatively smaller dose, but IV insulin is the preferred route. So to sum up, a child with type 1 undergoing surgery is again like a mobile phone in roaming. Replenish carbs, replenish insulin, either IV or subcutaneous. Prevent the occurrence of DKA. The seventh question which a physician is likely to encounter is how to follow up a child or an adolescent with type 1 diabetes mellitus. Any electronic gadget would require periodic servicing. Similarly, every child with type 1 diabetes mellitus would definitely require a periodic surveillance. A logbook that tells us the reasons for the excursion in the sugar is extremely valuable. Screen the CBG values and see what is the percentage in the target, above the target and below the target. The more you check, better it is. Optimize for every child's control. The SMBG frequency should be tailored based on the needs of the child and financial consideration. And one should ensure that at least 50% of the CBG values are in target and try to maintain the HbA1c below 7 to 7.5% across the ages at least once in 3 months. The better you have a control, the better would be the long-term health of the child. Growth monitoring and sexual maturity monitoring. Extremely important. Growth is a barometer of well-being in a child. When you have an optimally growing, normally growing child with good catch-up growth, you know that your sugars are being managed well. It's an indirect surrogate of HbA1c. It's an indirect surrogate of CGM. This child was initially on premixed insulin. Once basal bolus was started, the HbA1c improved, and you can see the shift in the growth trajectory. The child was having a flat growth curve. Once you shifted the child to basal bolus regimen, look the shift up in terms of height and weight. A good catch-up growth is equal to good sugar control. If your speedometer is not working, when you see that the vehicle is moving, you know that the tank is full. Similarly, when you see that the child is moving on the growth curves, you know that the sugars are being managed well. Whenever you have a flat growth profile, poor growth, despite having good control, always rule out hypothyroidism. Poor growth velocity in any child, including a child with type 1 diabetes mellitus, in view of the association, as both are autoimmune problems, a poor growth velocity indicates that you have to check the thyroid status. Irrespective of symptoms, at least annually, a thyroid profile is mandatory. Whenever you have decline in the weight percentiles, you have growth faltering, poor growth, always keep in mind that the child may have celiac disease. Celiac disease is another autoimmune condition which might be associated with type 1 diabetes, relatively uncommon in the southern part of the country, but there is plethora of data that describes this dichotomy above and below the Tropic of Cancer, but it is not unreported. A significant group of children might develop celiac disease, so please do screen for them periodically, and if you have symptoms, definitely a TTG IgA should be done. A gluten-free diet is a simple measure that this child requires to have an optimal growth. And lastly, whenever you have rapid catch-up in weight, you have sudden shifting upwards of weight despite giving appropriate doses, strong clinical pointers like acanthosis nigricans, skin tag, a strong family history of type 2 diabetes mellitus with negative autoantibodies and without DKA at presentation, and a strong family history. Always keep in mind that there is not that all children with childhood diabetes do not have type 1 diabetes. Monogenic diabetes and type 2 diabetes as well should be considered in the appropriate setting. And the management would be a game changer. If you just put these children on oral hypoglycemic agents and lifestyle measures, you're going to have a good improvement in the glycemic control. So when you have specific clinical or biochemical pointers, keep in mind the possibility of non-type 1 diabetes as well, which is also reflected in the growth chart. And never forget to screen children with type 1 diabetes for complications as well as associated autoimmune disorders. Associated autoimmune disorders, as mentioned here, the possibility of wheat allergy, celiac disease, the possibility of hypothyroidism, and screening for complications, microvascular, macrovascular, and local complications. A urine albumin creatinine ratio for nephropathy, an indirect ophthalmoscopy for retinopathy, and a neurological examination for neuropathy. And ideally, every clinic visit, a blood pressure measurement, and annually a measurement of lipid profile is also recommended to look for the presence of dyslipidemia. This is recommended after 5 years of diabetic age in prepubertal children, or 2 years in pubertal children, or earlier if there is persistent suboptimal sugar control. So how to follow up a child? Always screen for autoimmune problems, complications, short-term glycemic control, growth, puberty. Everything, like a mobile phone, requires a proper screening of the various parts of the vehicle, various parts of the mobile. A child with type 1 diabetes mellitus must have a checklist, and every visit and every annually the child should be screened. I am bored of checking. I do not wish to have my sugars checked. I think this is one scenario every child and adolescent with type 1 diabetes mellitus is going to encounter at some point of their time. And this is a game changer. Continuous glucose monitoring system. It is a continuous measurement of sugars in the interstitial fluid. It is a video recording of sugar values versus a snapshot that is provided in the glucometer. You go for a wedding and see the album, it's a snapshot. You see the video, it looks as if you have gone to the wedding even though you have seen it virtually. The video recording of the sugar values is all what the CGM is about. It can be for professional or personal use. The personal use is increasingly being available and used across the various boards. It helps clinicians assess what is called is time in range. What percentage of time this individual child with type 1 diabetes spends in normal sugars, in subabnormal sugars, low sugars, and high sugars. The more the time the child spends in appropriate range, the more you fool the body to tell that the diabetes has gone away. The more efficiently you fool the body, the better is going to be the long-term health of the child in terms of prevention of complications. It's as such as you're transplanting the child and fooling the body. When you donate kidney, you fool the recipient's body saying that the kidney has become all right. When you use a CGM and ensure that the time in range is above 70%, you fool the body telling that the diabetes has gone away. You're spending predominant time in normal range. And it also gives a trend of sugars and an extrapolated HbA1c, which is extremely useful. In India, these two companies have made continuous glucose monitoring available for us. The Freestyle Libre from Abbott company and Guardian from the Medtronic company. And both of them are very good. They have a relatively good accuracy, and you are provided with a scanner. This Freestyle is an intermittently scanned. You have a near field technology enabled mobile phone, or you use a reader that is used to scan the sensor and the sugar values are recorded. Freestyle can be used above 4 years, and the cost is very much economically feasible and affordable for a majority strata of the society. And the other, it is approved for use in children above 4 years of age. There is a lot of data on it is used for 14 days. There is a lot of recent data which has explored the possibility of other brands of CGM with different technology on a longer duration and in very young children. They are probably in pipeline. In the days to come, it will be available for us. But at this point of time, these two are extremely useful wonder tools in our hand, which will empower our patients to care for themselves in a better way. And lastly, I am bored of insulins, I am bored of pens, I am bored of syringes. What is it that I can do? What is it that you can help me? I think this again, lot of explosion on the use of insulin pumps in individuals with type 1 diabetes mellitus, more physiological, more time in range, reduced complication rate. You have multiple benefits. You have different basal rates to deliver different basal at different times of the day. Any number of boluses can be given, better glycemic control, and lot of additional tools. But always remember, the benefit depends on the driver, not the vehicle. So you must have a flair for technology. What is it that it does? It just gives appropriate doses based on guidance from the CGM. So what is it that is, what are the cons of insulin pump therapy? Higher cost, the risk of decay, being attached to the device, and other barriers as well. So the pump delivers the insulin through the reservoir into the infusion set and delivers appropriate doses of insulin. The newer 780G closes the loop and provides input to the pump on the sugar values. So you have a CGM which senses the sugar values, it gives message to the pump and delivers the appropriate dose. It's like a GPS driven system. If I want to go from one place to another place, I would take the help of GPS. Similarly, a CGM and a pump is I am driving an automatic car with the help of a GPS system. So my life is easier. The ISPAN 2022 guidelines strongly recommends sensor augmented pump. If you see conventional pumps, it was just available as a delivery device. But the sensor augmented pump, a GPS enabled driverless car, it functions like that. It is superior to MDI with self monitoring of blood glucose. It reduces HbA1c without increasing the risk of hypoglycemia or severe hypoglycemia, especially in those with poor controls, complications, high fluctuations, recurrent severe hypoglycemia, needle phobia, ketosis proneness, etc. It's a wonder tool provided you have a flare for it. This is the most advanced model that is currently available. AI based adjustment, no need to do carb counting, corrects for hypoglycemia, improves the time and range, and has smart guard technology, an automatic driverless car which is driven by GPS. I would say is what the 780G pump is all about. If you see conventionally what we do in basal bolus regimen, we check the sugar with a glucometer, understand the diet, and deliver the insulin. In a 780G, the CGM checks the sugar, AI decides the dose, and the pump delivers the insulin. See how the burden has been eased from the patient to the system. But of course, it comes at a cost. This is available at a premium cost and it's not available in rental schemes currently. It's not only a one-time basic cost, but also the recurring cost that comes in terms of the consumables and the sensor. I think a lot of schemes are coming up on making this affordable and available to all strata of the society. I'm sure in the days to come, we are going to have more and more children and adolescents on pump. This is some of the works from our unit. These are some of the publications from our unit. Just to sum up the answers for the 10 focused question. Why childhood diabetes is different from adult DM? Because the childhood component is also an added element in the type 1 diabetes management. The ideal regimen is basal bolus. Ideal regimen is basal bolus. Ideal regimen is basal bolus. No role for pre-mixed insulin. A normal, healthy, balanced diet with adequate carbs, proteins, fats, vitamins and minerals that facilitates the growth of the child is the diet that is recommended. CBG below 70 is hypoglycemia, classified as mild, moderate or severe. Follow the rule of 15 or glucagon or IV dextrose bolus. Whenever a child type 1 DM is having an unaccustomed exercise, check more, avoid hypo. Whenever a child with type 1 diabetes is sick, check ketones, prevent TKA. Whenever a child with type 1 diabetes is going to undergo a surgery, have a team approach, husband-wife relationship with the theatre, prevent DKA, ensure a smooth surgery takes place. Minor surgery, just skip the bolus. Major surgery, IV fluids and IV insulin. How would you monitor the child? A logbook, HbA1c, screening for comorbidities, autoimmune disorders like hypothyroidism and celiac disease, screening for complications like nephropathy, retinopathy, neuropathy, dyslipidemia and hypertension. A growth chart is mandatory in every child with type 1 diabetes mellitus. The continuous glucose monitoring system is emerging as a good alternative to sugar check, and the automated sensor augmented pump is probably what the future holds for children and adolescents with type 1 diabetes mellitus. I end my talk on that note. Thank you very much, and I hope I have adhered to the time that is stipulated. Thank you.
Perfect timing, Dr. Hemchand. Over to you, Dr. Parvati. We have enough time for questions.
Yeah.
Your comments
Thank you,
first, Dr. Parvati.
Yeah, sure. Dr. Hemchand, thank you so much for this wonderful talk. He has put up the more important points, especially mentioning that the childhood diabetes is totally different from an adult type 2 diabetes, and what are the challenges we as clinicians and the family faces, and what are the optimal methods to overcome these challenges. So I agree totally with all the points put forward by Dr. Hemchand. We have few questions. One question is already answered by Dr. Ravi Shankar, but I think it's a pertinent question. What is the best insulin regimen for type 2 diabetes in a teenager? And when would you add metformin?
I think the International Society of Pediatric and Adolescent Diabetes has given very simple, crystal clear guidelines on management of type 2 diabetes in adolescents. I think if the child is above 10 years and a diagnosis of type 2 diabetes is pertinent, it depends on the clinical scenario and the level of HbA1c. If the child is sick, is in DKA, I think the recommendation is always to start the child on basal bolus regimen, stabilize the child, slowly withdraw the insulin. If you have a relatively stable child, symptomatic child with a high HbA1c above 9%, I think that's a recommendation to add basal insulin and metformin. When it's an asymptomatic child identified on routine screening and the HbA1c is not very high, so somewhere between 6.5 to 8.5, I think one would start the child just on metformin and lifestyle measures. Liraglutide is emerging as a very, very popular alternative. I think that also can be used as a second line medication in appropriate situations.
Very true. Definitely in the initial setting, it might be difficult to differentiate between type 1 and type 2. So initial management definitely depends upon the glycemic control. So the sugars are very high, as Dr. Hemchand rightly pointed out, if the HbA1c is more than 9% and you have very high sugars, it's always better to start on basal bolus regimen, follow up the child closely, let the reports come, and let us have a look at the glucose trend, and then we'll decide on adding metformin and slowly taking off insulin and enforcing lifestyle changes, which would definitely improve the type 2 diabetes. Dr. Ravi Shankar has asked, what is the scene in India for locally manufactured CGMs and insulin pumps?
See, I think to my knowledge, the regulatory authorities have licensed the use of two CGMs at this point of time. The intermittently scanned CGM is from Abbott, which is Freestyle Libre, and the real-time CGM is from the Medtronic Guardian Connect. The benefit of using the Medtronic one is that it's a real-time one, does not require scanning, but the cost comes at a premium one because you have a transmitter that is required to and it's compatible with the pump as well. The transmitter cost adds up to the bill in terms of additional 50,000. Regarding the Abbott, I think that's a practical and a very, very useful one to just explore technology because it's economically viable for most families. And now with the NFC, near field communication technology, which they have incorporated in the newer ones, most of the mobile phones, they say except China phones, all phones will be able to do that. So you don't need an additional reader as such. The mobile phone acts as a scanner which depicts the CBG values for us. So it serves as a very economically useful one. So I think this is what is the way forward in terms of continuous glucose monitoring these two systems. It just comes at a cost of around 5,500 for 14 days, which I think is a worthwhile investment in the to at least to understand what is really happening because it's real time. You can take action and see whether your action is right or wrong. You're seeing a speedometer and adjusting your speed, that kind of a system. It's much better than driving a vehicle without having a speedometer. Regarding pumps, I think I reiterate what was told. Pump as a delivery device, the ISPAT 2022 guidelines just looks at it as a delivery device, but a sensor augmented pump, the newer 780G, which is linked to a CGM. The CGM checks the sugar, guides the pump through the Bluetooth, and the pump delivers the insulin. adjust the speed up and down, adjust the doses up and down based on the CGM is definitely available, feasible, and should definitely be recommended in the right situation. But just as a delivery to, unless it translates into an improved glycemic control, I don't think we should embark upon resorting to pump therapy just for the sake of convenience, I would say.
So there's no manufactured in India CGM or pump yet. Is that it?
What is available right now is from the Medtronic company. They are multinational companies which provides us with the 780G pump and the basic model pumps, and Abbott.
Local manufacturing, I think we are yet to be there, Dr. Ravi Shankar. And two important challenges which Dr. Hemchand mentioned. The major challenge, I think, educating the healthcare providers is also very important. Many of the times we have late diagnosis in type 1 diabetes in children, landing in severe diabetic ketoacidosis, which increases the morbidity and mortality. So once in a while, we do get severe decay. So usually the symptoms of diabetes in children are many of the times overlooked. So this increased urination or increased thirst and weight loss might be overlooked based on the particular climate. So it's very important to be aware and to check the blood sugar when children come with symptoms. So now type 1 diabetes, as we know, as per the statistics in the last IDF 2022, India is topping the list. The maximum number of young people with type 1 diabetes is in India. So it's definitely important to diagnose it early and overcome the challenges of treatment with the multidisciplinary team. And Dr. Ravi Shankar has also commented on immunotherapy. I think immunotherapy in prevention of type 1 diabetes, probably he's speaking about tocilizumab, which is yet to be, I think it's in the pipeline. Dr. Ravi Shankar, do you want to?
Yeah, I think teplizumab is probably what is there in mind. I think that is focused. On a practical note, we have I think two challenges. One, availability of teplizumab, which is difficult to procure. But there are certain patients who are able to get a hand on them through their own private channels. So that is definitely one thing which we have to, making the medication available. And second thing is affordable. It is extremely expensive. And number three, getting clearance from regulatory authorities on its use in children. I think that is also something which we have to explore. Probably it is recommended in relatives of individuals with type 1 diabetes who are in the pre-symptomatic phase of type 1 diabetes mellitus. Maybe twins, one is affected, one is unaffected. You have the positive, and the criteria, if you see in that TrialNet, they needed the presence of 2 autoantibodies, age above 8 years. So if you follow all the regulatory, the statutory requirements, I think in the days to come, that's definitely going to be very popular in individuals with type 1 diabetes mellitus, especially siblings and first degree relatives.
Dr. Parvati, Ravi wanted to say something?
Yeah, I just wanted to check on a couple of things. How frequently are you able to measure autoantibodies in patients presenting with type 1 diabetes like phenotype, and also any comment about the type 1.5 or people who have both autoantibodies and features of type 2 diabetes? I mean, those are the patients where we could never withdraw insulin completely. They needed some amount of insulin on board at all times. So
I think as far as the practice here is concerned, I think anti-GAD antibody is the most commonly measured antibody, which is supposed to be most commonly prevalent and helps us pin the diagnosis of type 1 diabetes mellitus. And there are a lot of commercial laboratories who have come up with autoimmune panels which measure 5 antibodies in one go. So I think that is also available. And here in Chennai, we have the MGR University, which is able to help us with the anti-GAD antibody in a very reasonable cost per se. So I think even the establishing the diagnosis of type 1 diabetes is with a positive antibody is definitely feasible, especially if anti-GAD is negative, you go in for the panel and you're able to pin the diagnosis of type 1 diabetes mellitus. Regarding the possibility of type 1.5 diabetes mellitus, I think that is something which is a big challenge to treating clinicians, as well as to counseling the families about, as parents, they want to know what is the cause for diabetes. Is it type 1 or type 2? Give a clear answer, which is practically very difficult in this so-called 1.5 type of diabetes mellitus, who are extremely obese, who have a strong family history, who have features of insulin resistance, and who do have a significantly positive autoantibody titer as well. So they are the group of children who go on something like a cocktail, and we always have to juggle around, putting them on a combination of oral medications, lifestyle measures, and insulin, and try to withdraw and see if they are able to be keeping HbA1c as a target. You'll really have to keep them juggled around.
Same here. I also practice in doing only GAD65 antibody initially. When do I do the panel? For example, we have a diagnostic confusion, especially there is a confusion between the glucose trends to be very low. We are confused if it's a honeymoon phase or is it not type 1. So then we go for the panel. For example, last week we did a panel and we got 3 antibodies positive and a low C-peptide. So that family has been counseled for more of a possibility of type 1 and to keep the sugars under check and plan to restart insulin accordingly.
So here in the US, I think there's a huge push to use teplizumab in stage 2 type 1 to prevent them to going into stage 3. I think the data suggest a delay of at least 2 years, a median delay of about 2 years. But there's a huge push to do that. So which means that a huge number of first-degree relatives will have to be screened to see if they meet the criteria, because obviously the patient, it's too late. We do have a lot of trials, or at least a handful of trials that are going on in patients with type 1 diabetes for immunotherapy to save whatever beta cell function is left, or maybe even prevent more beta cell destruction, because beta cells are being formed throughout life. So if we stop the destruction, then obviously there'll be more of those. And of course, there's these stem cell transplant groups that are working really hard. So, the future looks bright. But until that happens, my experience has been that the designer insulins, the CGMs, even the freestyle Libres, and definitely the pumps, they are quite expensive, particularly in rural India, where there are more than a handful of patients with type 1 diabetes currently. So it's in the management of patients like that where, things become really terrible. And the worst thing is that many of those patients are being managed by internists or general practitioners who have no idea what to do. They treat patients with insulin without educating them on hypoglycemia, which I think is the most dangerous situation. So that's why my questions about locally sourced pumps and locally sourced CGMs. Hopefully it'll bring the cost down and make them more available to people all over India.
Yes, Dr. Ravishankar, actually in Kerala, we have a scheme called Mithai scheme under the government of Kerala. So all the medical colleges and the government health centers, few of the selected community health centers have this Mithai clinic where a doctor who is trained in pediatric diabetes management would be there. And these children who come under the, low socioeconomic status, they are provided insulin with strips, and few of them have been receiving, I think around probably less than 10 have received insulin pumps with certain Rotary teams getting into it and providing the consumables. So a lot of support system is happening, I think all over India. Don't
but
you
is
agree?
It only for Kerala? That sounds very interesting. Yeah. Is it only for Kerala?
the government initiated program is there for, I think, only Kerala, but Tamil Nadu has a lot of other NGOs. Am I right, Dr. Hemchand? I think.
Yeah, there is a very strong NGO which is working on providing a lot of the underprivileged sections with free insulin pumps and CGMs as well. So I think all the children go definitely onto basal bolus regimen only, and they provide free insulin and strips on a monthly basis. So this definitely in a very positive note.
Can someone put the NGO in the chat box, please?
Name of the NGO you're asking?
Yes, correct.
I think Dr. Hemchand can help. Sure.
Yeah, there's another question. Meanwhile, what about the insulin pods and sensors? Can one import these and use these in India?
Insulin pot, if you're asking, Medtronic had a pot, but I think we couldn't get great results with that, and I think they have withdrawn that. Insulin pot, I think for giving injections. That's what you have asked. That's what I suppose.
AML is the name of the NGO run by Dr. Swaminathan.
Idayangal is the name. Idayangal.
And in Karnataka also, we have quite a number of camps for foreign children. And in the Indira Gandhi Institute of Child Health, we have been dispensing free insulin, glucometers, strips, even lab investigation, regular follow-up with HbA1c, everything at a free. And this has been going on for almost 12 years, and it is still being continued. We have recently been able to get, with the help of Idayangal, child started on insulin pump as well. So there are a number of organizations, and there are some states like Goa, for example, where things are available. And ultimately, we need it on a country-wide basis, and a lot needs to be done. And it's always a pleasure to listen to Dr. Hemchand, and I enjoyed the lecture. And you gave so many clinical situations in such a short period of time. But I'm sure you will agree there are a myriad more situations which require. And every child is different. You said we have to manage children also along with their diabetes. We have to manage the family also. And this child is a child, but there are many children who take all the messages to their heart. And even toddlers have done well, I can show you some. But not everybody does the same thing. Adolescents, so much so, I've wondered whether they have honeymoon period, as Parvati was also saying. There are some very, very good patients, but unfortunately, this is a chronic disorder which requires attention almost round the clock, not like other diseases which can be cured with a course of antibiotics or something like that. And people are not aware that there is some illness like this which requires constant attention. And everybody wants a magic cure. Everybody wants a driverless car, as you were saying. And it's not that simple. Type 1 diabetes is always very difficult. And attention has to be paid to so much details. And anyway, we have a great task ahead. We are trying our best to do whatever we can. And I hope this will come under a government scheme on a national basis. I hope so. The program in India for changing diabetes in children, CBS program, was started and was held in 22 centers all over India, offering about 4,000 and giving all the treatment free. And this was supposed to be a model for the government to take from there. But unfortunately, it didn't happen, and it is still being practiced with help from NGOs and all that. And I hope nationwide basis.
Thank you, sir.
So, Dr. one of the questions in the chat box, and also someone else whom I shared the link with had asked me about how are we dealing with the psychological fallout of children who have diabetes, like mental health and well-being. What can be done for that?
I think ensuring that they meet children with the same problem, having support groups of parents and families. When one old family educates and takes care of another old family, and now with this WhatsApp coming up in connecting these families in big way, I think there are innumerable number of groups which kind of connect the dots and bring these children in touch with each other. There are a lot of support group meetings. There are a lot of these individuals who have type 1 diabetes have grown up to become big warriors, positive changers, and motivators. They organize meetings in smaller towns as well periodically, and they probably encouraging them to be a part of those meetings, interacting and getting to know people of the same fraternity. Would be simple ways, and of course at the right juncture referring them to a mental health professional also would be an important component in the care, who is a mental health professional who kind of has an inclination, orientation to type 1 diabetes. Would also be an important valuable team member in helping us cope up with this strategy.
Thank you.
Vidya, can I ask a question?
Sure.
So one of the major things that we find a big problem here in the United States are social issues, where many families, not the educated and well-to-do ones, but in many other families, parental supervision is really hard to find. So they think it's the child's disease, the child has to live with it. So the sooner they start taking responsibility for it, the better they will be. But we know from a lot of lines of research that that's really not true. They're not cognitively able to understand the need to, do the routine checks, take the injections, etc. So how much of that is a problem? Because we end up calling CPS on them many times. We've had to go to court and sort of provide documentation so that the children are actually removed from their home and put in a foster care environment where they are provided better supervision. So that's one aspect that I was wondering what it is in India. The second aspect is that we used to see with a lot of adolescent girls. They would take a minimum amount of insulin to prevent DKA, but then they would pee out the rest of their glucose for weight control, because otherwise they were, gaining weight. Is that an issue that you see in India? I see you smiling, so I guess that is something you see. So just a couple of comments on both those issues.
Yeah, thank you. I think eating disorders is definitely has percolated from the Western world into the Indian world. A good prevalence of eating disorders has crept in, especially in the individuals with type 1 diabetes mellitus. Both incomplete and complete forms of anorexia nervosa, bulimia nervosa, etc. are documented, and people come with that diagnosis as well. And they are diagnosed by a qualified psychiatrist based on the ICD criteria. So it's not something which is not there. It is definitely there. Probably what as seen in the other parts of the world as well, the adolescent girls who are very conscious about their in body image, and from the upper and upper middle socioeconomic strata seem to be developing this group of problems. And I think involvement and constant supervision by a social worker and the close scrutiny with the mental health professional is probably the way forward. Most of the times they are brought into the hospital, and they are now monitored for life-threatening complications, including dyselectrolytemia, arrhythmias, etc. And they are kept inpatient, and dietary counseling, etc. is reinforced. And at some point of time, there was even a need to go in for invasive procedures like gastrostomy to improve their nutrition. And so it's a very complicated scenario. And I think a tertiary care center with all necessary allied health professionals and other professionals would definitely be the way forward in tackling this. But definitely that has come in, and it's a nightmare to handle, like for any other clinician.
May I make a comment here?
Yes,
Please,
Yes.
sir.
I think the situation in India is different from that in US. Having worked abroad and having worked here, I can say that the parents here are much more uh, caring about the children. Quite often, the children adjust themselves to the diabetes, and it is the parents who require a lot of support. And they will be crying all the time. And I have to say, you should not cry in front of the children. You should be solid pillars of support. And they also, I mean, they mean it, but they require also quite a lot of support. And parent groups help quite often. And having some diabetes camps, I have held quite a number. And all those things add to the confidence. And we recently had the World Diabetes Day, and a large number of children attended the meeting. I think almost 200 children came. And the mother, one of the mothers, told me that the very first uh, Diabetes Day program that she attended filled her with a lot of confidence. And so parent groups are very, very important. And they add support to our mission in treating diabetes. And I think that's one good positive aspect that I have noticed.
right.
Thank you, sir. And just to add a note, there's a lot of support available from the grandparents, the social, the other members around the family, who kind of the child becomes the center point, and they all position themselves around the child and try to contribute their bit in the betterment and care. The amount of sacrifices which parents do in terms of giving up their career, in terms of shifting their residences, and is indeed innumerable. I think that is something which is definitely something we all have to look up to them and learn from them in taking care of their children with type 1 diabetes.
There is a fundamental question in the chat box. What is the incidence of type 1 diabetes in India? I assume the person means in children, but nevertheless.
I
I think
recently read.
Yes, Dr. Hemchand.
I think in the recent papers, I'm not able to offhand look up and tell, but there are a lot of registries and they have reported it recently. I'm not able to quote a number.
I think as per the last 2022 IDF Atlas, around 2.8 lakhs children with type 1 diabetes are in India, and that's the maximum number. And there is a alarming increase in incidence of type 1 diabetes every year.
Srividya, you have your camera on. Did you want to add something?
Yeah, hi. Really, really very interesting topic to discuss, where we are on the precipice of increased type 2 diabetes. How are we handling type 1? A very interesting anecdotal. So we have at Apollo something called as Apollo Shine, in which we do school health survey. We have around 3 lakh children data, in which we found almost 2.5 to 3.5% have full-fledged type 2 diabetes. And around 2% have type 1 also, which is undetected. So, I mean, I'm talking about in an incomplete data set of around 3 lakh children, wherein many of them do not even have, they've not even completed the format. So, it's a very, very scary statistics right now, which we have. But the one thing which I have noticed in my practice is that there is a lot of ADHD along with type 1 diabetes. I do not know what is this association. ADHD boys with type 1 diabetes. Dr. Hemchand, can you throw any light on that?
I think these glycemic excursions which do take place in these children with type 1 diabetes, both in terms of hypoglycemia and hyperglycemia, it has been reported that these sort of behavioral problems are known to occur in individuals. And the only way of combating this strategy is optimize and reduce the fluctuations and variability, the glycemic variability, bring it down, and obviously you would see a good improvement in these symptoms.
I think no autoimmune connection, Dr. Hemchand. I mean, we've not been able to establish any.
Not to my knowledge.
Not okay. Because they very distinctly, we are seeing a pattern of type 1, or maybe that's how the personality is, we don't know. But thank you very much for really very good talk.
Thank you.
There's another question in the chat box. Are there any good movies or documentaries available for children and parents with diabetes? Because now the visual, the age of, visual thing, rather than talking or giving something to read, is there anything that you suggest for children and parents?
I'm not aware of any movies, Dr. Hemchand can say, but there are few, now there are YouTube bloggers. So there are a lot of useful blogs. For example, Diabetes is a good YouTube channel that has been started by Jas Sethi, the daughter of Geet Sethi, the billiards player. So she's running I think she's associated with an NGO and doing a lot of work in type 1 diabetes. So there are a lot of online support systems also, which patients can refer to.
If you could just type the details in the chat box of so that whoever's asked the question can get the answer. If anyone has any questions, please feel free to either turn on your camera or raise your hand. Otherwise, Bani, your camera's on.
There's one more question, madam. Is swimming allowed for type 1 diabetes? I believe if the family and the child is being trained with a bit of planning, as Dr. Hemchand was mentioning clearly, to check the blood sugar before the planned exercise and probably half an hour after the exercise, and optimizing or titrating your insulin dose based on the type of exercise you're doing. For example, if you're going for a prolonged swimming, you can reduce bolus insulin by 25 to 30%. And if you check the sugars, prolonged exercise can reduce your sugars for the next 24 to 48 hours. So it's always important to be mindful on your sugars. If the bedtime sugars are low, you need to reduce the long-acting, the basal insulin also. So with a bit of planning, any exercise is allowed for. They need not be prohibited from doing any sports.
So, Vani, you have your camera on. You need to unmute yourself. You're muted, Vani.
I don't have much. I'm a gynecologist, so I know a little bit of diabetes depending on gestational diabetes. But in St. John's, I had managed a type 1 diabetic, and she had 200 relatives in Telangana with diabetes. And recently, a friend of mine, her daughter has diabetes. She's 10. She had collapsed when they were abroad, and then they picked up the type 1 diabetes, and they had to change her school, and she was very quiet and very disturbed. So I picked up a few points here to at least tell my friend. Exercise was one thing I've picked up, and psychological counseling and help groups. It was extremely useful. I wanted to thank the speakers. It was very useful.
Thank you.
So Vidya, can I just add one thing, which is sort of tangential? So it's really very interesting how, type 1 diabetes is at the sort of cusp between immunologists who deal with the basic underlying problem and endocrinologists who treat the disease. It's becoming very similar in type 2 diabetes, where the endocrinologists handle the metabolic consequences, but then now you have the nephrologists and you have the cardiologists all getting involved in the whole management. So what I'm trying to say is that these are all things that require a huge team effort to provide the best sort of care, if not for an individual patient, at least for developing practice guidelines. So it's very important that everybody works in concert. Just like Dr. Hemchand mentioned about having a husband and wife relationship, this is a relationship with practically every medical specialty to provide the best sort of care, or at least care guidelines to these patients. It's just amazing how medicine in the last several years has evolved to a point where that kind of collaboration is necessary.
Shiva, you had your hand up. Did you want to say something? Shiva Pillai?
Yeah, we did a pediatrician here who works with me did an interesting study because we're doing fetal medicine, and one of the things that we have found is that if you don't control gestational diabetes very well, the first thing we need to say is that between type 1 and type 2 diabetes is becoming a little bit blurred and it's merging into one another. And we found that if you don't control gestational diabetes very well, and if the neonates have neonatal hypoglycemia, one of the pediatricians here followed up patients, the children up to 20 years, and we found that 18.4% of those that were had neonatal hypoglycemia actually became diabetics quite early before the age of 20 years. He's still following up the rest and he's going to publish after another 10 years, the next study to follow to 30 years. So I wanted to say to Vani and others, if you're being an obstetrician, controlling diabetes in pregnant mothers may be one of the ways in preventing future diabetics in patients. That's the one thing that I wanted to say. The second thing is that, as you know, myself, I'm a diabetic on continuous glucose monitoring. Not enough attention has been paid when you put patients on fixed regimes like basal bolus on diet and the exchange of what you can exchange, how much food you can exchange, and which food you can exchange with what, and to keep the diets complex, but with having the exchange criteria. This is something one of the NGOs here is working on, and to produce food that are culturally acceptable. You can't go to, for example, a Kosa family and say, eat a South Mediterranean diet. They are not going to eat that. So you need to make the food also custom to cultural practices and such that you have balanced diets that with exchange, that you can do what is called carb exchange so that your basal bolus regime can be in correction at all times and keep the child in control. Thanks.
Dr. Hemchand, would you like to respond to that?
Yeah, I think the Indian diet, understanding it and optimizing it is extremely challenging. And a lot of work has gone on recently. Even the RSSDA has come up with the dietary guidelines. So I think, yes, the wholesome management and advice on diet, optimizing and preparing and giving them a carbohydrate containing list or an exchange list so that they can exchange one food for the other, take one food instead of the other, so that the total carbohydrate content does not get altered is extremely important. And all of us should work on, who are taking care of individuals with diabetes, should spend some time and give them some valuable inputs on carbohydrate counting and understanding the concept of this exchanging one food for the other, so that the sugar excursions do not occur.
Right. We are almost out of time. Radhakrishna, you skipped faculty dinner to attend this. You have something to say?
Firstly, I really enjoyed the talk because it's so simple and the possibly deals with pediatric patients. So, his way of teaching all of us as though he's teaching children, the children will be able to understand what he says to start with. I really like the way he started saying, you just don't manage diabetes, you manage childhood. I think that's a very significant comment. I haven't heard that before. And then his way of comparing with mobile phones and cars and petrol, I think is something very interesting and very novel. I really liked it. And then my the questions will be, if at what age will these children transfer to adult diabetologists, or do you continue to treat them? One question. One question two is, do these type 1 diabetic children, they live a complete normal life, or they develop problems earlier? And finally, Vidya, if a movie is not being made, we should make one if Dr. Hemchand agrees.
Thank you, sir. I think at the age of 18 years, all of us would transfer the care of individuals with type 1 diabetes to adult physicians and adult endocrinologists, adult diabetologists. And the 100% they lead a normal life. I think that is what is the concept of basal bolus. In every aspect, they lead a normal life. And in terms of complication rate, if you look at the recent data that is emerging on complication rates of individuals with type 1 diabetes, with the advent of basal bolus regimen, with the advent of with the advent of intense insulin regimen, the complication rates are very minimal. If at all the complication rates are there, it's mainly related to dyslipidemia rather than microvascular complications like nephropathy and retinopathy. So if you give them a good A1C, the complication rate is extremely minimal. So they 100% lead a normal life.
It's a wonderful talk. Thank you so much.
So there is a question here that any points on managing patients on peg feeds with diabetes?
Peg feeds would be
directly going into the stomach. You have a percutaneous gastrostomy.
See, this I have encountered this as a problem in children with CF related diabetes. Is probably the only situation where I have encountered this pig feeds. And I think that is relatively easy because those are artificially calculated feeds with very strict carbohydrate content. So if you're aware of an insulin carbohydrate ratio, then I think managing that on subcutaneous insulin is relatively simple. Some of them are on some protein shakes, or they are on some preparations that are given through gastrostomy feeds. I think the concept remains the same. Match the carbs in the food. Adjust the insulin for the carbohydrate content of the food based on the tolerability, weight, and the age when the feed is given, and the appropriate dose of bolus is given. So I think the principle remains the same.
Compared to oral intake, it should be easier because the amount is fixed and the formula is also fixed. So Dr. Parvati, any closing comments?
Yeah, thank you for giving me this opportunity to moderate this wonderful session on type 1 diabetes, challenges in childhood diabetes, especially in the month of November, which is a diabetes awareness month. And recently we had a World Diabetes Day celebration. This year's theme was breaking barriers and bridging gaps. I think we are all here in this meeting talking about childhood diabetes to break the barriers and bridge the gaps. So thank you, Dr. Hemchand, for a wonderful talk. Thank you, Dr. Vidya, for inviting me. And thank you, Raghupati sir, for joining us and giving your valuable inputs.
Yeah, your closing comment, Dr. Hemchand.
Thank you very much. Thank you for this nice talk. I think the message is only one. All children, no pre-mixed insulin, only basal bolus, only basal bolus, only basal. The route of administration, whether it is syringe, pen, pump, is immaterial. Preparation, whether you use an analog or whether you use regular, is immaterial. I think the concept of adjusting the cap size for the head, adjusting the sock size for the foot, adjusting the glove size for the hand is more important than doing something vice versa.
Thank you, everybody. We had a very interactive session and a lot of questions, though the numbers may have been low, probably because so many conferences are going on, physical conferences are going on, being the month of November. So we were happy to do something on pediatrics because November 14th is also Children's Day. So diabetes, children, everything. So we're very happy to have made this session happen. We'll meet again next week with another episode of Marvelous Medicine, which will be a non-medical topic, Beyond Medicine. And our Dr. Jayakumar Menon from Kerala will be speaking on mythology. So those who had saturated with a lot of medical webinars, you're most welcome to log into something different. Thank you, everyone, for joining. Good night and stay safe.
Thank you, ma'am. Thank you so much.
And good
Thank
night.
you.